Now we'll transition to our next talk. Um, Dr. Matthew Burg. Dr. Matthew Burg is professor of internal medicine in the section of cardiovascular medicine at Yale School of Medicine. For over 30 years, he has directed a program of research funded by the Department of Veterans Affairs and the NIH, focused on the role that stress and negative emotion play as contributors to incident cardiovascular disease, the expression of disease, and prognosis. He's also directed and participated in several clinical trials, testing approaches to mitigate the risk associated with stress and negative emotion. His earliest studies using ecological momentary assessment relied on paper pencil recordings by patients, later moving to Palm Pilot technology, which I admire that work. That we tried some of that. That's pretty tough. In his current studies concerning stress and hypertension risk, he's using the LifeData platform, and he will be describing these studies in his presentation today. The title of that presentation is Daily Stress and Hypertension Risk, and his collaborators are Joseph Schwartz, Christy Harris, and Allison Gaffey. So again, you can use the Q&A feature there to list questions that you may have, and we will have time for that at the end. So without further ado, Matthew, Dr. Berg, if you're
Yep.
ready, ready to hand it over to you. And thank you for your time in presenting with us today.
Great. So I'm sharing the screen. That's that one.
Yep. And there should
Okay.
be a video if you'd like to do that as well.
Okay. So we'll move to slideshow. Can everybody see that?
I think so.
Okay, great. So thanks for that introduction. I'm happy to be here today. And as Jason said, I'll be talking about stress, emotion, and cardiovascular disease and how we're using ecological momentary assessment in a couple of our studies that are underway. And I always like to start off with this slide to kind of put it in a context that an understanding or an appreciation of how stress and emotion can affect the heart is really quite old. We date this from the Greek physician Celsus, who said fear and anger and any other state of mind may often be apt to excite the pulse. And more recently, Osler, who was a pioneer of modern medicine, in lectures on angina pectoris, the chest pain that accompanies heart disease, published in The Lancet, said it's not the delicate person who's prone to angina, but the robust, the vigorous in mind and body, the keen and ambitious man whose engine is always at full throttle. And for those who have been around long enough, this and remembers the days of the type A behavior pattern, this description really captures that emotion, the cognitive emotional complex that was in the 1960s and 70s found to be associated with cardiovascular disease risk. And so, you know, more recently, efforts to reduce the incidence of cardiovascular disease have led to the identification of major risk factors that I'm sure we all know about, things like tobacco use, sedentary lifestyle, high cholesterol, diabetes, obesity. And for the studies that we're that we have underway right now, we've chosen to focus on hypertension risk. And one area that we've done this or are doing this is in the context of post-traumatic stress disorder. It's a chronic stress condition that occurs among individuals exposed to traumatic events such as combat, intimate partner violence, and natural disasters. In the general population, the lifetime prevalence is just around 4.5%, but in military veterans can range up above 30%. It's associated with a range of disabling symptoms, intrusive thoughts, nightmares, flashbacks, which is a reliving of the traumatic experience. And because of that avoidance of reminders or situations in the natural environment that serve as reminders of that traumatic experience, we chose to focus on post-traumatic stress disorder based on some earlier work we had done with a meta-analysis that revealed that post-traumatic stress disorder diagnosis is associated with increased risk for early heart disease and early heart disease-related mortality. And with the understanding that with the operations, the military operations that were put into effect after the September 11th tragedies in New York and at the Pentagon, at the World Trade Center at the Pentagon, all of those military operations that were launched. And what we were then seeing was this younger cohort of military veterans with multiple deployments whose prevalence of post-traumatic stress disorder is really quite high. And we saw this as an opportunity to start to understand the linkage of post-traumatic stress disorder to risk for heart disease much earlier. Whereas the Vietnam era cohort taught us this link when they already had heart disease, we saw this as an opportunity to get an earlier understanding and perhaps lead to actionable targets for reducing this risk. But with the growing awareness that PTSD contributes to elevated risk, it's associated with a host of risk behaviors like smoking, alcohol use, non-adherence, but it's often accompanied by exaggerated heart rate and blood pressure, and an exaggerated heart rate and blood pressure response to stressful stimuli with alterations in the autonomic nervous system and HPA axis regulation. And it's also associated with blood-based indices of endothelial dysfunction, which is a very earlier marker of a disease, a vascular disease process, and of low-grade inflammation. And again, cardiovascular disease is a disease of inflammation. So again, this kind of had us really focusing on this younger cohort of veterans. In earlier work, PTSD had been linked to hypertension prevalence, and in a study that we did using electronic health record data from the Department of Veterans Affairs, specifically looking at post 9/11 veterans, we tested the prospective relationship of a PTSD diagnosis to an incident diagnosis of hypertension. And we modeled it in 3 ways. 1, with a new diagnosis in the electronic health record. 2, with a new prescription for an antihypertensive medication in the absence of a diagnosis. And 3, with multiple blood pressure recordings in the hypertensive range on clinic visits. And what we found was that PTSD was associated with between a 26% and 57% greater risk of incident hypertension. But of course, we're dealing with administrative data, and there are limits. While administrative data, electronic health record data can be informative, there are limits in terms of coding and things of that kind. So we wanted to do a more focused study, and we've been doing work using ambulatory blood pressure monitoring for a number of years. Ambulatory blood pressure monitoring measures the blood pressure during daily life, and typically what you do is you have this person wear the blood pressure cuff. It's a cuff with the tube, standard like a blood pressure measuring device, connected to a device that's about the size of a cigarette pack that the person carries with them. They can wear it in a holster around their waist or around their shoulder. And typically we program this to take a recording every 30 minutes. And this is during the daytime and during the night while they're sleeping. We will typically get a 24-hour recording. Some labs do it for up to 48 hours. It's not a pleasant thing to wear. It's not pleasant to have a blood pressure taken every 30 minutes as you go about your daily routine, and so that's a limit. And in this study, we did it for 24 hours as we typically do. Why ambulatory blood pressure monitoring is so important is that the resting clinic blood pressure, number one, it's typically not taken at a research quality. So it's not a very reliable measure in that from one measurement to the next, there can be a lot of variability. And 2, research has consistently found that if you want to predict outcomes, target organ damage, and cardiovascular disease events, it's not as, the resting clinic blood pressure is not as good as the ambulatory blood pressure. Even a 24-hour average or a daytime average blood pressure is more predictive of outcomes. Another thing we wanted to focus on was sleep quality, and we know that post-traumatic stress disorder is associated with poor sleep quality, at very least because of the nightmares that often accompany this. And poor sleep quality contributes to an elevated blood pressure and to inflammation, and disturbances of sleep quality can be captured with actigraphy. So again, hallmark of PTSD is this heightened emotional and arousal with combining ambulatory blood pressure monitoring with ecological momentary assessment. You create a powerful real world tool whereby you can look at the effects on a momentary basis of what the person's emotional state is, what the effect is on their blood pressure or the relationship. Because you're getting, let's say in a 16-hour day, you're getting up to over 30 readings, 30 blood pressure readings with linked ecological momentary assessment. When we then combine it with sleep actigraphy, we're also then seeing the relationship of sleep quality to the blood pressure. And we can also look at what the person's daytime experience was like in terms of their emotional experiences during the day. How does that relate to their sleep on that night? And then how does that all relate to their blood pressure? So the specific aims of this study were to test whether PTSD symptom severity in these veterans is cross-sectionally associated with ambulatory blood pressure, whether their symptoms today are associated with their change in blood pressure over a 2-year period, the 2-year increase, and to look at their ambulatory blood pressure response to momentary negative emotions and specifically to PTSD symptoms. The sample is 300 veterans post 9/11 operations Iraqi Freedom, Operations Enduring Freedom. These are the kind of acronyms that the VA uses: OIF, OEF, OND. As I said, assessment at baseline and 2-year follow-up, PTSD symptom severity. We are also looking at treatment, lifetime exposure to trauma, deployment history, health risk behaviors as covariates, medical and psychosocial covariates. As I said, 24-hour ambulatory blood pressure monitoring in concert with detailed EMA. This is a user-initiated survey because each time the blood pressure cuff takes a reading, the person after the reading is supposed to open up the app and make a recording. And then we're also, for this study, using an additional 7-day notification initiated survey of PTSD symptoms. And then we're also doing the 7-day sleep monitoring by actigraphy. Just to give you a sense of, this is what the blood pressure monitor looks like, and this is what the ActiWatch looks like. They wear this on their wrist. You can see there's a little light sensor there so that we know if the light is off, and it's one more check on their sleep habits. This is some screenshots from an earlier study we did. But more importantly, I'm not sure how well this displays. This gives you a sense of the kinds of questions that we're asking just before blood pressure recording. Were you reclining, sitting? We need to know what your posture was. We need to know how much physical exertion you were engaging in, your location. Were you eating, drinking caffeinated beverage, alcohol, smoking a cigarette? These are all important things because we know these affect blood pressure. And so we need to control for these in all the analyses so that we can look at the kinds of things we're most interested in, which come next. Before, how irritated, aggravated, frustrated, or angry were you? And happy, anxious, tense, tired, fatigued. These are all individual questions that are answered on a horizontal VAS scale, where the person just uses the app to press, to indicate on a line how their level of experiencing that mood from not at all to very much. We want to know if they were with others and who that person was. Oops, sorry. The quality of that interaction and other aspects of that interaction. And this is more or less the user-initiated survey template. Again, what we're most interested here is looking at the relationship of the specific mood to blood pressure, controlling for these other factors. With regard to the notification initiated template. These are the kinds of questions that we were asking 3 times a day. Specific to PTSD, have you been troubled by thoughts about your military service? Have you been troubled by thoughts about something else in your life? Have you avoided people, activities, or situations? So here we're getting into the avoidance and some degree of reliving or perseverative thinking. We're also interested at the end of the day, how good was your day? How satisfied? How difficult was it for you to focus? A PTSD related factor. How connected did you feel because of the social distancing? And how difficult was it for you to wind down from the day? Again, these are PTSD relevant questions. We have some very preliminary data where as you can see here, we're looking at hypertension categories. And what we do here is if you take the clinic blood pressure, and the resting blood pressure can be above or below the threshold that defines hypertension. And so you get 2 fields, so to speak. And then if you cross that with the ambulatory blood pressure, again, you get the average daytime, the threshold is above or below what would be defined as hypertension. So you get 4 cells that define normotensive. It is below that threshold on the ambulatory basis and on the resting basis. Masked hypertension is defined as an ambulatory blood pressure, average ambulatory blood pressure that's above threshold for hypertension, whereas the resting blood pressure is below that threshold. And it's as if the ambulatory is telling you this person has hypertension, but if you only look in the resting setting, you're not seeing it. So the hypertension is masked. Essential is when it's elevated in both contexts, and white coat hypertension is when it's only elevated at rest, and that describes a reactivity to the assessment being done by an individual. And what we can see here is that endorsement of being troubled about thoughts, having troubled thoughts about military is more prevalent and higher in these hypertension categories. And a 1-point increase in this PTSD related EMA assessment is associated with a 0.5 millimeter mercury increase in systolic blood pressure. It may not seem like a lot, but when you think about the scale is on a 0 to 100 basis, you can see how that could get big, that effect can be pronounced. So I want to now move to our next study. And this is a study of arterial stiffness, which is related to blood pressure, but it again describes a constituent factor of the arterial system that contributes to hypertension. So starting off with the background, you know, as we know, cardiovascular disease risk is highest in developed nations. And one of the things we know about developed nations is that on average, the population of developed nations reports higher stress and insufficient sleep, and each of these affect the health of the vascular system. Arterial stiffness is a property that describes the structural remodeling of large arteries. They become less elastic, and we see this with aging, and that's why aging is one of the strongest contributors to hypertension risk. We know that arterial stiffness is an early predictor of risk, but it's findings that are based on a single time resting assessment of arterial stiffness. The person is lying down and you're measuring the stiffness of the large vessels. But emerging research was suggesting that psychological stress and other things and insufficient sleep each affect arterial stiffness dynamically, that the stiffness changes on a dynamic basis throughout the day. There is a resting chronic level of stiffness. However, there's a dynamic element to that as well. And so critical gap in knowledge concerns the effects of modifiable factors on this momentary arterial stiffening that may contribute to a permanent increase in this property. And this can include stress and sleep. And in a pilot study, we found that EMA psychological stress was associated with significant momentary increase in stiffness, and those with the greatest response to stiffness response to a laboratory psychological stress also evidenced higher daytime average. So real world arterial stiffness may be due to repeated instances of stiffening during psychological stress. And so we are conducting a combined field and laboratory study. And in the field, with a sample approaching 300, we are now on hold until the until the embargo on research activities is lifted due to the coronavirus. A field study of 300 with 7 days of sleep monitoring, 1 day of apnea assessment, and a 36-hour ambulatory stiffness monitoring with EMA. And again, here the EMA is user initiated with each recording of arterial stiffness. The person completes an EMA assessment. The assessment of arterial stiffness, it's just like an ambulatory blood pressure monitor. It's just that with added software in the monitor itself, it's able to capture waveforms, not just the systolic point and the diastolic point, so that in capturing the waveform, it captures reflective waves, which are indicative of how stiff the large vessels are. The stiffer the vessels, the faster the blood moves through the system, and the faster it's moving, the earlier the reflective wave that is captured. We're then taking people into the laboratory and manipulate on the hospital research unit, and we're manipulating sleep. We're doing a mental stress task the morning after a good night's sleep and the morning after a poor night's sleep, the sleep being manipulated. In terms of the user-initiated survey template, we're particularly interested here in social interaction and rumination about these kinds of negative interactions. We're asking the same sorts of questions about posture, ingestions, level of physical exertion, the same emotion questions in terms of how irritated, aggravated, angry are you, how happy, how sad, how anxious, etc. But here we're adding these additional questions about interactions, the pleasantness of the interaction, how you felt about the interaction, if it was an argument, how you feel about that person, confidence in your ability to handle the situation, and whether during at the time of this assessment, did you think about something that previously made you angry, and how long did you think about it? So again, capturing that ruminative element. We're interested in this because of the hypothesis that if something makes me angry, it might have an effect on my blood pressure now. If I continue to think about that, does it continue to have an effect on my blood pressure, or in this case, on the stiffness of my large arteries? And our hypothesis is that yes, rumination, especially about things that previously made the person angry, will have a prolonged effect on the vascular system. And this is based on a large body of literature showing that, that if you have a person describe a previous incident that made them angry, you will see pronounced cardiovascular effects as they're telling you about this previous incident. So this study, as I said, is underway. Out of an N of 300, we're at about 200, at about 210. And we're on course. With that, I'll put it open to questions.
Great, thank you so much, Matthew. I've got one question here. It says, great study. Can you talk about your decision process about what to include in the responses for the question of what are you doing? We've struggled with this question because there's so many options, and you obviously want to limit the number of response options. And I'll say we've struggled with that too. Our initial study and the subsequent studies is how to frame that question. Any thoughts about that?
Yeah, so again, for these studies, the "what are you doing" part, that general question that's early in the survey, is very focused on the physical. it's really designed to capture aspects that we know we need to control for in our analyses. That while we believe, and there's data to support the notion that momentary emotion affects momentary blood pressure, we also know that if what I'm doing is engaging in something strenuous, the effect of that doing will be much greater than the effect of whatever my mood is at that moment. And so for us, it's not as difficult a decision of what to include, and to the largest extent is tagged to metrics that have been long developed about the level of exertion associated with different kinds of activities. And so you know, for us again, it was a much more confined question that that we needed to figure out.
Yeah, makes sense. So this next question is, does the ambulatory monitor measure at exact intervals, or is it partly random? So is it being measured? And I think this is about the blood pressure in
Yes.
particular. Can the patient anticipate when the measurement is about to happen and make modifications to behavior, posture, so forth? Is there, I guess, reactivity to that?
Yes. So that's a great question. There is a bit of you have the ability to create a window. It's a narrow window. So it's taking a reading on average every 30 minutes, plus or minus 5 minutes. In terms of how the person might be reactive, if they're moving and they continue to move, the device will not be able to capture the blood pressure.
Hmm.
What will happen is it will inflate, it will get an error, it will then wait 30 seconds or a minute and inflate again, and it will do that 3 times and then stop. So the instruction is when the cuff starts to inflate, if you're moving your arm, stop moving your arm,
Yeah.
um, just because of that. Um, we anticipate some degree of reactivity. The thing is that mostly people, what we find is, if anything, people don't, if they're whatever they're doing, if it starts to inflate, they don't stop. And so while we ideally in a 24-hour period would get 48 readings, it's very rare that we get 48 valid readings for a given 24-hour recording period. And we understand that. And, so we set thresholds when we do our data analysis. We set thresholds of what's the minimum number of readings that that we that are necessary for this to be a valid study for this participant.
Thanks. This next question is also a reactivity question, more to the questioning. Thank you for your very nice studies. In study 1, do you think that asking veterans about troubling thoughts, their military service, is there some reactivity to that? Will that influence the reports? I could imagine it may be stressful to know you'll be asked this multiple times, which may influence BP. That's the question.
Yes, so I think that's a great question, and that's something that we really put a lot of thought into. How do you capture these occurrences without provoking them, essentially? If the person's going about their business and you're saying, thinking about, since it's now 11 o'clock, since this morning, have you had any troubling thoughts about your military experience? No, but now I am.
Yeah.
Thing. And we at the VA hospital where I'm located, VA Connecticut Healthcare System, it's one of the national centers for the study of post-traumatic stress disorder. And we spoke with colleagues, and the feeling was that by leaving the questions more general, troubling thoughts, rather than specifically, for example, tagging it to items on the post-traumatic, the PTSD checklist, that it left it vague enough that we wouldn't get the reactivity. And you know, we did some debriefs with participants, and our feeling is that we really aren't seeing that reactivity. They're not reporting that, gee whiz, I was fine until you asked me that question.
Yeah.
One of the other interesting things, and unfortunately this, I didn't have a chance to put a slide together for this, is that, you know, PTSD is a syndrome, and the person needs to have so many of different checklists, and some of which are necessary, some of which are sufficient. And then and that's for the diagnostic interview. And for the PTSD checklist, there are similar thresholds, and it's a paper pencil assessment. What we find is that if you do 7 days of EMA, that the correlation between the EMA values and the values on the checklist and with the interview are so high that the EMA may be a really good way, um, that involves a low amount of staff burden, to at least identify people who are likely to be um, have elevated symptoms high enough even for diagnostic purposes. So that's an interesting side finding.
Yeah. Well, thank you. Thank you so much
You're
for
welcome.
sharing with us today. Hope you have a good rest of your day.
You too.
Yeah. Thank you.